Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we focus on practical strategies for initiating and maintaining people with HIV on long-acting Cabotegravir plus Rilpivirine. How should it be started? What are the practical considerations? To answer these questions and more, I'm joined by Dr. Ian Frank from the University of Pennsylvania. For more information about Dr. Frank and this program, and to follow along with the slides, please visit the links in the show notes for this episode. Now, let's get started and hear what Dr. Frank has to say about the use of long-acting Cabotegravir plus Rilpivirine for treating people with HIV.
I'm going to be talking about long-acting therapy for treatment. So this long-acting injectable therapy regimen was first approved by the Food and Drug Administration about 2 years ago now, in January 2021. And the approval was modified in February of last year to allow for every 2-month injections instead of the monthly injections, which were the way the regimen was initially approved. But there are challenges. People need to come in for their appointments into a clinical area. They can't self-administer the drug. There's concerns about integrase inhibitors and increasing weight and therefore body mass. And there's logistical issues as well. Cost can be a challenge. Insurance doesn't always approve long-acting injectable therapy. And there may be some concerns about tolerability and toxicity, and we'll talk about some of these issues. So the guidance on the use of long-acting Cabotegravir and Rilpivirine is based upon, in some ways, the way the studies were done. And so the studies were done in individuals who were virologically suppressed on an oral regimen for 3 to 6 months. They could have any renal function. Neither of these drugs have an impact on renal health. Obviously, people need to be engaged in their healthcare because they're going to need to come in for their injections. And certainly, if they're getting injections on a monthly basis, they're likely to be seen more frequently than they would be if they were getting care and taking an oral regimen. So they have to agree to come in frequently. The main contraindication to the use of injectable Cabotegravir or Rilpivirine is baseline resistance, either integrase resistance or NNRTI resistance, because those are the two classes represented by this combination. If somebody had previously been noted to have a K103N mutation, that wouldn't be a contraindication to their receiving this injectable therapy. Rilpivirine is fully active if individuals have just an isolated K103N mutation. There's a contraindication, which is virologic failure. So individuals would have needed to be infected with resistant virus rather than failing on a regimen in order to qualify based upon the FDA approval for the product to receive this injectable combination. And neither of these drugs are active against hepatitis B. So folks with chronic hepatitis B viral infection should be on an alternative regimen. The approval to use the drugs at a every 2-month interval comes from the Atlas 2M study. The Atlas 2 study was a study that initially compared oral versus injectable therapy that was given at every 1-month interval. And then individuals had an opportunity to roll over into the Atlas 2M study, in which some people would remain on every 1-month injectable therapy. Some people would then start on every 2-month therapy or roll over from every 1-month injectable therapy to every 2-month injectable therapy. So there was a couple of different ways to enter this study. Some people were switching from an oral regimen. Some people were switching from injectable therapy already. In the intent to treat analysis, everybody is experiencing virologic success. Confirmed virologic failure, 2 viral loads greater than 50 copies in a row, were more likely to be seen in the folks that were assigned to the every 8-week injectable strategy rather than the every 4-week injectable strategy. And we'll talk about risks for virologic failure in a moment. People who had confirmed virologic failure were likely to experience resistance. 9 of the 11 people with confirmed virologic failure on the every 8-week interval regimen developed NNRTI resistance, and 8 of the 11 developed integrase resistance. Only 2 people had confirmed virologic failure on the every 4-week regimen, but resistance was common, including integrase resistance. So there's some risk for this strategy not working. And the regimen was generally well tolerated. 99% of the injection site reactions were graded as being of mild or moderate severity, and they lasted on average about 3 days. And the proportion of individuals who withdrew from study participation because of injection site reactions were few, only 2% when given every 8 weeks and 3% when given every 4 weeks. And people preferred to get the injections at 8-week intervals rather than every 2-week intervals. And obviously that makes a lot of sense. So what are the risk factors for confirmed virologic failure or virologic failure on this injectable therapy? And for this analysis, we're going to be looking at that Atlas study and also a different study called the FLAIR study, which was also a study where individuals were switched from an oral regimen to every 4-week injectable therapy. And in this analysis, the risks for virologic failure were Rilpivirine resistance at baseline. That increased the risk of resistance or failure 40-fold, a low trough concentration of Rilpivirine. Having subtype A, either A6 or A1 virus, subtype A virus is most commonly encountered in Eastern Europe, not in the Americas, where the most common subtype is type B. So that's not going to be a factor that's likely to influence failure in our patients. And having a BMI that's a little on the high side. If individuals didn't have any of these risk factors for failure, 95% of people had an undetectable viral load. If they had one, basically the same proportion had an undetectable viral load. But if people had 2 or more of these risk factors, the probability of virologic failure increased to 26%. So we certainly want to avoid some of these factors, and some of these factors we're not going to know when making the decision to initiate therapy. We're not going to know what their 8-week trough concentration to either of the drugs is going to be. If you've gotten a resistance test, know whether or not they have any baseline resistance to any of the NNRTIs, with the exception of that K103N single mutation. We'll know what their BMI is. If you order a resistance test, you may not have noticed, but the resistance test will generally tell you what subtype the virus is. So you probably know that as well. Okay, now let's talk about some of the practical information about administering long-acting Cabotegravir and Rilpivirine. And so, as I've alluded to, there's 2 different kinds of strategies. There's an every 4-week strategy, and there's an every 8-week strategy. And the dose of the product and the administration schedule is a little bit different. So if we're going to be initiating therapy with a patient who says, I'm happy to take the injections at every month, I'd like to come in here, then we're going to start with a high-dose injection, 600 milligrams of Cabotegravir, 900 milligrams of Rilpivirine. We're going to give that injection at baseline, and then we are going to continue with injections at every 4-week intervals at a slightly lower dose, 400 and 600. This is if we go direct to inject. The other strategy is with an oral lead-in, where folks take oral Cabotegravir, Rilpivirine for a month, and then they go to the every 1 month injectable dose. So that's the every 4-week direct to inject strategy. For the every 2-month direct to inject strategy, we start with 2 injections given 1 month apart. And when I say 2 injections, 2 combination injections, each injection is actually 2 injections, 3 milliliters each. And the injections are administered in the gluteus medius, usually one drug on one cheek, the other drug in the other cheek. If for whatever reason you can't give both injections in separate cheeks, you can give them in one cheek, but you need to separate them by about 3 or 4 centimeters. So back to the every 2-month injections, you start with 2 series of injections at the higher dose, 1 month apart, and then you skip a month and you continue with every 2-month injections. And you can see here, we're continuing with the higher injection rather than the higher dose. We're continuing with the higher dose rather than with the lower dose that we use at every 4-week intervals. So we've got to make sure that when we're ordering these products, we're ordering the correct dose for the initial injection and the correct dose, depending upon the dosing frequency, for follow-up injections. The injections need to be delivered by a healthcare provider. It's not supposed to be, like giving a shot in the arm for a vaccine. They're supposed to be administered with a Z injection technique. You put the needle in, you move the needle to the side, and then you push the needle in a little bit further, and that's to decrease the chance of any drug dripping out of the injection site after its administration. If people are on the oral lead-in, which they're taking for a month, obviously you want to assess their tolerability before moving to the injections. In our practice here in Philadelphia, we're going direct to inject. It seems that people tolerate the drug pretty well. The size of the needle that you are using to administer the product does vary by BMI. It should be a 23 gauge needle, 1.5 inches in length, except if somebody has a BMI greater than 30, in which case you should be using a 2-inch needle. And again, you give the injections in the gluteus medius on opposite sides. And if you need to give them on the same side, you need to separate them by an inch or more. It seems to be that the injection site reactions are generally well tolerated and not an obstacle. So who's a candidate for this? How can we support patients? Again, people need to be willing to come to us. It may be possible for pharmacies to deliver the shots. I'm not aware of pharmacies doing that now, but pharmacies are increasingly eager to give injectable therapies, and we may be seeing more pharmacies willing to give injectable antiretrovirals as well. Patients need to be reminded to have a supply of oral therapy, and that doesn't need to be oral Cabotegravir Rilpivirine. It could be oral Cabotegravir Rilpivirine, or it could be the last antiretroviral agent people were on prior to switching to injectable therapy. And they need this in case there's a reason for not being able to come in to get their next injection in the appropriate time frame, which if they're getting injections at 1 month intervals is basically 1 week before or after the injection. And if they're getting their injections at 2-month intervals, the window is 2 weeks before or after their injection. And it may be, that there'll be a strategy where we'll be able to go to people's homes or neighborhoods and give them injections on a mobile unit or provide them some incentives to get their injectable therapy. Now, unfortunately, many of the people who we would most like to give long-acting injectable therapy to do not have an undetectable viral load. We'd love to give this therapy to people who aren't particularly adherent and maybe don't come to our clinic at the right frequency. And these are the people where long-acting injectable therapy may really change their lives. And we are just starting to get a glimpse of using this long-acting injectable combination in individuals with detectable viral loads. And the first larger series that we have available to us comes from San Francisco. their Ward 86 clinic. And this is a clinic that serves many underserved individuals. 58% of these folks have unstable housing, 8% homeless. Most of them have either Medicare or Medicaid, a high rate of substance use and mental illness. This was a population where there was a concern about people being able to adhere to their regimen, but people said, we'll at least come into care. We'll at least come in at the interval you tell us to. But these were people who historically have not been virologically suppressed. And you can see that 43% of this population ended up not being virologically suppressed even after agreeing to come in and theoretically agreeing to take an oral regimen. So how well did this combination do in these individuals? So 57 patients with viremia and 55 of these individuals achieved virologic suppression basically within a month of starting on the strategy. Two didn't, and these two individuals did develop resistance, either NNRTI or integrase resistance. So obviously, there's a risk for the strategy not working. But these were individuals who demonstrated that taking antiretrovirals orally was a challenge for them, and they needed a different kind of option. And this is a pretty good response that the strategy changed the lives of a number of individuals. And there were some individuals who said, I would have been dead were it not for this kind of treatment. So there's a lot of interest in giving this regimen to other individuals who aren't virologically suppressed, and we'll see more of that data in the near future. There's also a little bit of real-world data on injectable CAB and Rilpivirine that comes from this OPERA cohort. This is a very large cohort of 96 clinics across the U.S., over 145,000 people with HIV under care in these clinics. And they were able to track 383 individuals who started on Cabotegravir and Rilpivirine sometime between January 2021 and February 2022. Remember, at this time, the only strategy that was approved was an every 1 month injectable strategy. Every 2 month injectable strategies were not FDA approved. And you can see that just about everybody has a viral load less than 200 copies. And there are very few individuals who have experienced virologic failure. About 10% of either the first or second injections were outside the appropriate window by 9 days or more. So we're starting to gather some real world experience, and we'll have more of these kinds of cohort data available to us in the future to understand how effective the strategy is in practices that are like our own and not in a clinical trial context. One more study I want to share with you called the SOLAR study. This is a study that's switching people who are virologically suppressed on Cabotegravir TAF FTC to injectable Cabotegravir or Rilpivirine, or continuing on oral therapy. And folks are randomized to continue or to switch to injectable therapy. And people had the option of either starting right away on injectable therapy or starting on oral Cabotegravir and Rilpivirine, and then moving on to injectable therapy. And here the injections were given at every 2 month intervals. And so we're going to follow people for about a year and see how people are doing on therapy. The efficacy data is really just that injectable therapy was non-inferior to oral therapy. 447 individuals randomized to injectable therapy, 5 cases of virologic failure. That's an incidence of a little over 1%. One person with virologic failure out of 223 individuals who are continuing on Cabotegravir TAF FTC. So that's about 0.5%. with confirmed virologic failure. So the difference here is 0.5% population difference with respect to confirmed virologic failure. And that's a non-inferior outcome. This is a survey, a quality of life survey. And the question that's being addressed is your quality of life better on injectable therapy or oral therapy? And you can see things are more likely to improve if folks are on injectable therapy, and they get a little bit worse if people are continuing on their oral therapy. And you should just sort of keep in mind people are coming into the study because they are willing to get injectable therapy. So that's why they're in the study. And so you should consider these responses in that kind of context. Most people preferring to get injectable therapy if they were assigned to the injectable therapy arm and had the experience both with oral therapy and injectable therapy. Let me just say a little bit about weight gain in the study. There was really no change in weight in the people who continued on Cabotegravir. There was a slight decline in weight in the folks who were switching to Rilpivirine. The difference in weight gain here is 0.45 kilogram. That's about a pound over the course of the year. So not anything that's really going to influence decision, I think. Although if you look at categories of weight change, people who go from normal to overweight or people who go from overweight to obese, a slightly higher proportion of individuals increase in their category if they're continuing on oral therapy compared to switching to long-acting injectable therapy. So some change in weight and BMI in a select proportion of the individuals. But if you look on average, there's not going to be much of a change. And there was no difference between the two arms with respect to changes in hip or waist circumference or the development of insulin resistance or metabolic syndrome. So I'm not sure that there's much of a difference here with respect to metabolic changes. So if, again, people are getting injections at every 4-week intervals or every 8-week intervals, and then if they have unplanned reasons for delaying or missing doses, what should we do? Well, the first thing we should do is we should check their viral load and make sure that they're virologically suppressed. And if they have a detectable viral load, we want to get a resistance test. If they're virologically suppressed, here's what we should be doing. If they're virologically suppressed, if it's been less than 2 months since their last injection, we can continue on their normal dosing schedule. If it's more than 2 months since their last injection, then we need to give them the loading dose followed by every 4-week injections. And I should say that this slide just pertains to people who are getting monthly dosing. So this slide doesn't pertain to people who are getting every 2-month dosing. I'm going to show you that on the next slide. If we need to stop therapy, people should be transitioned to oral therapy within 4 weeks of their last shot to maintain adequate drug concentrations and prevent a viral rebound. If people are on every 1-month interval dosing and they want to switch to every 2-month interval dosing, we want to give them a shot with the high dose 1 month after their last dose, followed by every 2-month injections, again with the higher dose. So before going to every 2-month intervals, we want to give them one shot with a high dose. Okay, now let's say people are on every 2-month intervals and and they've missed a dose. What do? Again, we check their viral load. We do a resistance test if they're viremic. And if their injection is less than 2 months since their last injection, or if they missed their second dose, so we've given them the first high dose now, they've missed their second dose, what we want to do is resume the dosing schedule. If it's been more than 3 months since their first dose, we want to give the 2 loading doses again before we continue. If we've given the 2 loading doses and now we're giving the every 2-month dose, and it's been less than 3 months since their last shot, we can just continue giving them their doses every 2 months. If it's more than 3 months, we start again with the 2 loading doses 1 month apart. And again, if we're stopping therapy or transitioning back to oral therapy, we want to give them their regimen at least or within 8 weeks after their last injection. So it's confusing. Let me just sort of summarize it. This is the way I sort of remember it. If you're on whatever frequency you're on, if you're 1 month late beyond the frequency that you're getting, you can just continue. So that means if you're getting interval injections at 1 month, if you're 2 months late, or if you're getting injections every 2 months, if you're 3 months late or less, you can continue getting the injections that you were on. If you're more than 1 month plus your dosing interval, so greater than 2 months or greater than 3 months, then you start from the very beginning with your loading strategy before you move on to your dosing interval. So it's complicated. I hope you got that. If you're not used to giving these drugs, I would suggest, when people are late, you look it up to remind yourself of the appropriate dosing frequency.
Thank you very much to Dr. Frank, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2023 program on the Clinical Care Options website, and to access the slides for implementing long-acting ART in clinical practice, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.